may be here. I think it's a provisional apology. Any other apologies? No. Okay, thank you. Item 2 is chairperson's business. Just advising members that the Oireachtas Joint Committee on Health and Children have asked to meet with the committee in terms of our role as their counterpart to discuss issues, just areas of cooperation and of mutual concern in the health policy area. If members remember, the Health Committee travelled to Dublin to meet the Joint Committee in June 2012, and the Joint Committee wishes to return that visit. So I'm looking to seek agreement here to hold a working lunch informal meeting with the Joint Committee in the private dining room on Tuesday the 10th of February from 11:30 to 2 p.m. Obviously we will discuss in advance the formal agenda for the meeting, but at this point I'm seeking agreement to do that. Great. Thank you.
Menu in advance, please.
We can discuss all in advance. Also reminding members that the meeting on the 22nd of October, the committee had agreed to meet with representatives from the Scottish Communities for Health and Wellbeing to hear about the work that it does in terms of community-led approaches to health improvement, particularly in disadvantaged communities across Scotland, and processes around reducing health inequalities. Members, just to inform you that the committee staff have been liaising with representatives in relation to a possible visit to Scotland to explore the models around health inequalities and particular focus on preventative spend, given our ongoing work around budgetary allocations, and to consider where health sits in terms of the new community planning models and look at those models in Scotland. So I'm suggesting to the committee that we could combine this with a visit to the Scottish Parliament. I think it would be important because increasingly in a number of areas Scotland are being held up as an example of good practice, particularly in relation to preventative spend and in health inequalities. So I'm seeking members' approval to agree on a proposed visit, and then we can look at the working out of the arrangements for that.
Great.
Members in agreement? Okay, thank you. We can then, staff will identify obviously a suitable date and make the necessary arrangements. Also to advise members that Stephen Agnew MLA introduced a private members bill on Monday entitled the Children's Services Cooperation Bill. The purpose of the bill is to require departments to discharge their functions and cooperate with one another in order to contribute to the achievement of certain specified outcomes relating to the well-being of children and young people, and to amend the Children Order 1995. There are 6 clauses in the bill. Clause 4 aims to amend the Children Order 1995 by requiring Health and Social Care Board to review certain services and to produce a children and young persons services plan in cooperation with various other public bodies. The second stage has obviously not been scheduled yet, but I'm suggesting at this point, members, that the committee would write to the department in the first instance to ask for views on the bill, particularly in terms of clause 4 in relation to the review of Health and Social Care Board.
Yeah, great.
Members in agreement with that? Thank you. Also, just referring members to correspondence from the Huntington's Disease Association, which is at page 29 of your tabled papers. I know a number of members here met recently to discuss this issue. I met with the association yesterday. There has been a number of letters sent, have issued to the department in relation to the issues that have been raised here. There's a specific issue around how individual trusts manage this issue, and effectively how they manage services around this issue, and concern around particularly the 2 care coordinators posts and the fact that one is vacant. Can I suggest that we will again consider this matter once we receive that correspondence from the department?
Yeah.
Yeah. Thank you. Item 3, members, is the draft minutes of the meeting on Wednesday the 3rd of December. The minutes are on page 5. Are members content with the minutes?
Yeah.
Okay, item 4, members, is the review of the departmental approach to the budget, briefing by expert witnesses. Page 11 of the meeting folder and page 3 of the tabled meeting folder for the relevant papers. Just reminding members again that papers provided by other expert witnesses who were willing to give evidence to the committee but who could not be scheduled before the end of 2014 were emailed to members on Monday. Advising members that Professor Kieran O'Neill and Dr Pat McGregor are here today to give evidence on issues around resource allocation in the health service. You're both very welcome. Professor O'Neill is the Professor of Health Technology Assessment at the National University of Ireland, Galway, and Dr Pat McGregor is a former senior lecturer at the University of Ulster. So you're very welcome, folks. Thank you for taking the time to be with us. Can I ask you to make your opening comments, and then we can open it up to members for questions or commentary?
Surely, can we thank the committee for inviting us to speak to them today. In terms of the presentation, it's going to be a double act in some respects. Pat is going to speak about issues of strategy and some of the issues that arise from that, and then I'll come back to speak about some of the other areas that I'm given to understand the committee has an interest in around savings, revenues and international experience.
Thank you. Yes.
Well, as Kieran said, my intention here is to discuss the strategy and also, I think importantly, the information needed to inform it. Now, the recent interview of the Minister by this committee highlighted how the current funding crisis was dominating his mind, to the extent that he said, and I quote, "Are we making logical decisions? We are not. We are making practical decisions on which we can deliver," end quote. And I think to propose such a dichotomy between logic and thus strategy and practice is disturbing. The declared strategy for healthcare in Northern Ireland is given by Transforming Your Care, which argues for a greater emphasis on care in the community, whether being provided by general medical services, prevention or domestic support, and reducing the emphasis on acute services, which are naturally more expensive. Through the consultation process, this policy has received considerable support, but the Minister seems clearly to think that the implementation of the policy primarily is a financial commitment, which in the current circumstances cannot take first priority. Understandably, most of this discussion is in terms of expenditure. However, this can distract from strategic considerations and focus the discussion on inputs of the process rather than the outputs. Now, expenditure is a product of price and quantity in the first instance. The welfare of an expenditure allocation is the quantity of the service provided. An example where the policy tended to emphasise the inputs rather than the outputs is given by Agenda for Change. This was introduced for 59,000 staff in the health service in Northern Ireland in 2004. The total cost up to 2011-12 was $703 million. The 2012 health report of the Northern Ireland Audit Office found relatively few benefits of the knowledge and skill framework, which was the supposed objective, that occurred. And I think that highlights the importance that the outputs of the policy are essential, the key element in rational resource allocation. Thus, to assess any impact of policy demands data. So let's turn to TWC. How TYC?
TYC, yes.
I'm afraid I am now retired, and mentally I've started to generate at a fairly rapid rate.
We'll keep you right.
In terms of TYC, how is the implementation to be measured? If we look at the 2013-14 report of the HSC Board, there's a full account of various investments associated with this programme, but from it it's not possible to judge at all what's the overall position of the policy. And it is disturbing to note the limitation of some of the data series that what you consider are essential. For example, if we take GP numbers, only a headcount measure now is given by the BSO, should I say, since the whole time equivalent was discontinued after the GMS contract was introduced. Now, to judge the progress of TYC, ideally you would like fuller employment and output data from each of the sectors that constitute healthcare. The acute, primary and the caring. And it should be possible, without great difficulty, surely, to produce a statistical appendix to the HSC Board report containing employment and output data of those sectors. I think a further consideration of any strategic vision for healthcare is that provided by productivity. The health service in Northern Ireland in general has lower productivity than the NHS in England. This means a given expenditure in Northern Ireland will achieve less output, whether in terms of operations performed or GP consultations. In order to assess the overall progress of care in Northern Ireland, it would be useful to produce an annual data series on the productivity of the service. Now, this is, has already been produced for points in time by a number of studies, and their annual reproduction should not be very costly or onerous. Now, a major cause of the lower productivity in Northern Ireland is a number of acute hospitals. TYC noted that Northern Ireland had about 10 acute hospitals where in GB you would get an area served by 4. Political structure in Northern Ireland stresses consensus, and it's entirely reasonable to oppose closures, and many of the electorate in fact do. In many ways, I think the political structure we have here tends to make radical change much more difficult because the avenues of opposition, so to speak, are larger. I would consider, though, that regular publishing of cost data on hospitals, for example, will make it much more possible to focus the discussion upon the efficient provision of healthcare, particularly in the current budget situation.
I can now take over. The uncertainty regarding the budget which will be available, I can imagine, causes considerable difficulties for the department and for the Minister in planning for the future. That said, and picking up on some of the points that Pat has already made, I think it is nevertheless possible, and I would imagine has in actual fact been done, that contingencies have been planned for. So where the department at times talks about inescapable pressures or unavoidable pressures, I think it is worth bearing in mind that in a number of areas choices can nevertheless be made, and it is incumbent upon them to make those choices and inform them with good information. So, for example, in relation to guidance being issued by NICE, that is just guidance. There is no requisite on the department to necessarily adopt it. It would be subject to budget being available and subject to what economists would refer to as the opportunity cost associated with investing in those particular areas. There is certainly the scope there within the department to do horizon scanning in respect of what might come out of NICE. Similarly, if we look at some of the perennial potential areas for cost saving or for revenue generation. We would contend that there exists the wherewithal within the department and the information that it has available for it to model in a robust fashion what might be associated with a range of different contingencies. So in some of the work that we have undertaken previously, we noticed a disagreement between the department and the Audit Office, for example, in relation to administrative staffing. That's something that they should be able to resolve, get to the bottom of, and produce contingencies around whether or not there exists potential further savings in that area. If I turn briefly to revenue generation, we noted in the exchanges between the Minister and the Committee in October that, again, some of the old chestnuts were produced as potential areas for revenue generation and for cost saving. So one of them in particular is the pharmacy budget, and this is one which is returned to perennially. Since the evidence was given by the Minister, we note the production of an Audit Office report which suggests that there exists the potential for further savings were the Department, were the Health Service in Northern Ireland to increase its prescribing of generics as opposed to branded medicines. And the figures there range from 19 million to 73 million, depending upon the extent to which one believes further efficiencies can be gained. What we would suggest is that there exists the potential, there exists the information and the skills within the department to actually model that and see what is possible, and move the debate on from what is the level of potential savings into where those savings, how those savings, I should say, can actually be affected. Other areas were the sale of real estate and the use of excess capacity within the service, for example, having people from the Republic of Ireland use services here as a way of generating revenue. And we would expect the department to have, at an advanced stage, an idea as to what the potential savings, or revenue generation, I should say, are associated with that. Two areas that I think are in particular worthy of further attention, or greater attention than they have perhaps received to date, are around disinvestment. In other words, reducing the amount of low-value care which is delivered within the health service in Northern Ireland. And I would point to international work in Canada and in New Zealand, to name but two, which is looking at this, or has looked at this in the past, and shown where, within the context of a changing budget, services can be withdrawn, activities can be reduced, as a way of reprioritising what the health service actually does. And similarly then, in relation to the leftward shift proposed in transforming your care, again what I would expect to see from the department is a range of modelling exercises done to see, as I referred to in the briefing paper, what the rate of return is associated with, for example, investment in various prevention measures, as a way of guiding the implementation of activities such as transforming your care. And I referenced some examples of this in the paper, and I'll not go over them. One area that was mentioned in the exchange between the Minister and the Committee back in October was the potential for the reintroduction of prescription charges. And a figure was mentioned there as to the potential savings or revenue which could be accrued were those to be reintroduced. Similar to what I've already said in respect of the switch to generics, I don't see why that cannot in actual fact be modelled, and disagreements about the potential revenue generated there can in actual fact be evidence-based rather than opinion-based. And if the department and if the executive are interested in further revenue generation, not just from prescription charges, it could look to other international experience. So, for example, and I think this was covered in the evidence, the potential to introduce charges for GPs. I'm not advocating it, I'm just saying that it could be looked at. And also an extension of prescription charges. In Italy, for example, they charge not just for prescriptions, but they actually charge the equivalent of a prescription charge for tests which are conducted within a GP, whether it be a blood test or a urine test. There there are sound reasons why you may not choose to do that, why the department may not choose to do those things, but at least they can be fleshed out and explored. So that concludes our presentation.
Well, thank you both very much. Extremely useful paper. I suppose from the committee's point of view, the kind of central finding of your work is that funding or resources is allocated almost pro rata, and there doesn't seem to be any evidence or very little evidence of any strategic direction in relation to that, and that's certainly something that I would share, and certainly was a finding that was coming forward through our scrutiny of the 15-16 budget going forward. But there's a number of things that you highlight, and I just want to refer to. First of all, the issue about competition and the system, and you seem to suggest throughout the paper that there isn't enough, and that almost the 2009 Act focused on cooperation, consultation, as opposed to competition. And I'm just wondering how you respond then to criticisms around competition in the system. And I'm just mindful of a report that was issued today, I think through the BBC, where looking at the health service in England, but where the British Medical Association had said that enforcing competition in the NHS has not only led to services being fragmented, making the delivery of high-quality joined-up care more difficult, but it has also diverted vital funding away from frontline services to costly, complicated tendering processes.
I think the issue of competition in the NHS is obviously an area of some controversy, where I think people's prejudices as well as their reading of the evidence comes into it. I think the advantage, if you look at the commissioning process in Northern Ireland, it is quite, although it's called commissioning, it is quite radically different to England, in the sense that the commissioning body in England will have a series of products or services at once, and it can allocate those to suitable either trusts or the private sector. Now, I think that does put a pressure on trusts, obviously, to look at their costs very closely. In Northern Ireland, it's quite radically different. When the capitation formula is worked out for Northern Ireland, you get involved in it an adjustment for economies of scale. So if the provision of service in a particular trust area, let's say, is based on smaller hospitals or whatever, at a higher cost, it will be compensated for that in the capitation formula. Now, I think that reduces considerably the incentive to minimise costs. I think in England, if we take the restructuring of acute care, there is a very strong motive there on behalf of the trust to reduce inefficient units. I think in Northern Ireland that incentive is not there. Now, it can be compensated for in different ways, undoubtedly. But I think the advantage of a market, as an economist, is something you're told really from day one, would be that the decision-making is decentralised in that respect, and that you have got local bodies who are interested in that area of cost minimisation in the first instance.
Okay, thank you.
If I
Yeah,
could
sure.
come in on
Brilliant.
that as well. There's abundant evidence to suggest that a market in healthcare has failings associated with it. And we're not espousing the introduction of a market in healthcare. What we're suggesting is that competition can provide discipline, but there are other ways of providing discipline. There are other ways of holding providers to account, and that within a system which emphasises cooperation and consensus, those mechanisms may not be used as fully as they could be.
Okay. I mean, one of the issues, I suppose, I mean, your paper, in effect, doesn't pull any punches. I mean, it highlights issues around, weak political leadership. It highlights issues around poor performance against targets. Your own contribution initially talked about the need for data processes as well, and certainly how a policy direction like Transforming Your Care is actually monitored in terms of eradicating health outcomes, and all of that I absolutely agree with in relation to this. But I mean, I'm wondering specifically in terms of the data analysis. Even if we leave that to the one side, are there other suggestions about how we can improve performance generally? And I'm thinking, and you touched on it there, but the Minister has recently announced a review of the health and social care in terms of the administrative structures. Now, we're not quite clear on the terms of reference for that yet, but have you any thoughts on how that could be made more effective?
I think in actual fact, from the outside, it's quite difficult to get an accurate picture of the administrative structure. And obviously, on this committee, you have the advantage of having a former minister here. I think in our paper, we had the model of a classic bureaucracy, where the decisions went from the top to the bottom. On consideration, I think there is probably more leeway than that. That in the economics today, principal agent model is very fashionable, and the key difference between the principal and the agent is information. The agent knows his performance far better, or her performance far better than the principal does, and various ways of trying to get around that. But I think it's useful to think of that as a central problem. The advantage, I think, of the competition, and as I say, talking purely from the theory rather than how you would introduce any system, or whether any such system would be desirable or practical in Northern Ireland, is that the decision making is pushed further down the line. Now, this is very much also in line with what the NHS England is singing in their 5 years forward paper. One size does not fit all. And I think it would be, one system which you can guarantee will not work is decision making from the top down.
That's useful, and it probably leads on to another point around the targeting of resources. I suppose specifically when we look at Transforming Your Care and how the budget allocation will target health inequalities. And there's been some work in England that shows and demonstrates that when resources are targeted to more disadvantaged communities, there can be better outcomes. Is there thinking from your work and around that?
There's sometimes in the literature it's talked about as there being a trade-off between equity and efficiency. And I don't think that that's necessarily the case, that it may be the case that you can, in actual fact, both deliver services and ensure the utilisation of services in a manner which is more equitable and simultaneously increase the return in terms of health gain from the use of those resources as a result. So work, not part of what we have presented today, has looked at uptake of screening services in Northern Ireland, the Republic of Ireland and elsewhere, uptake of vaccination services, again in an international context, and demonstrated where there are disadvantaged groups, how targeting those and the barriers that they may face may not necessarily be financial barriers to access, and maybe other areas or other issues associated with health literacy, for example, where it is possible both to increase utilisation, benefit health for those who are disadvantaged, those who experience the inequality most, and improve overall population health in an efficient manner as a result. I'm happy to pass on some literature to the committee on that, should they so wish.
That would be very useful. Thank you very much. I have Kieran next.
Thanks, Chair, and thanks very much for your presentation. In relation to differences in other areas, what's your assessment on the main differences of patterns of spending in health and social services here in Northern Ireland and in other jurisdictions? I think you yourself, Pat, mentioned that earlier in your presentation.
Well, in a sense, I think it is important to distinguish between expenditures and the actual service being provided, because, in a sense, it's easy to talk in terms of expenditures, but unless you actually see what is being delivered on the ground, it's very hard to make any real judgment about it. And I think the agenda for change would be just one example. If you think of the TYC investments that the most recent board report has, all termed in expenditure. But, what actually on the ground changes? And that, I'd say from the outside, you can't judge.
Yeah, you mentioned, I think, comparison of hospitals here and hospitals across the water. Did you say that there was 10 hospitals here compared to 6 in GB?
I think
four. Yeah.
Well, that's at the beginning of the TYC report. That point is made.
And I mean, you think that's the right way? I mean, Kieran mentioned how difficult it was and is, particularly for elected representatives to face our constituents whenever there's a proposal to close a hospital.
I think in terms of the arithmetic, there are 108 MLAs. You will have them concentrate 6 per constituency.
Yeah.
Therefore, if there's a closure in a constituency, you will have 6 MLAs, 6 out of 100. Whereas in England, GB, you'll have 1, maybe 2 MPs out of over 600. Now, how you deal with that? I think, firstly, it's entirely reasonable for people to say, we want more acute hospitals. And, that is just an allocation process. If that's what people value, so be it. I think the issue that has to be brought much more to the forefront is what are the costs of that process. You have to say, for example, A&E provision. What type of provision are we going to get in a more distributed service? In terms of coverage, what sort of access to consultants and the like. So one only has to look at the TV to know how not only closure of hospitals, but closures of departments within hospitals, how they can become major press issues. I think if there is more information on the cost side, I think that is one way around it. At the end of the day, you know, we're in a democratic country. You know, it's entirely right if people want the distributed service that they get it. But I think the costs of that have to be clearly outlined.
Yeah. Again, correct me if I'm wrong, but Transforming Your Care does advocate a lessening of the number of acute hospitals in Northern Ireland. I'm not sure if I agree with that or not. But is it a case that in Across the Water where the decision has now been reversed, that it's they're saying, particularly in England, they're saying that it is preferential to have local acute hospitals where the population is, rather than less of them? You know, we're sort of almost going back to where we came from. I
think, again, you've got the data issue. The only data I've looked at, I think, refers to 2008. And getting hold of this type of data is not necessarily straightforward. I think you can't make sweeping judgment. And I think one of the things in the 5-year forward view is that one size will not fit all. But it's not just that you have an acute hospital, but how does that hospital link with primary services and care services? One example, actually produced in the 5-year forward discussion, was of Airedale, where they have the residential and nursing homes connected to the local hospital by secure video, which means that if there are issues with patients there, they can get consultation with nurses or consultants there. Now, the result is, I think, a drop of almost a third in A&E admissions and more than half in A&E attendances from the nursing homes. Now, I don't think it's a matter of acute hospital versus primary care, but how you merge the two together, I think requires a lot of development.
Right. And should we have a different balance of resourcing prevention, early intervention and public health? What do
I
you
think
reckon
that...
Simple answer to that is yes.
That's fine. Well, seeing you answered me in that one, and Chair, I'll finish. There was something you did say that I wasn't particularly happy with, and that is I am a firm believer that the National Health Service in this country was set up to be free at the point of delivery when people need it. Now, I think you did say in your presentation that we should look at the reintroduction of prescription charges. I'm happy to do that in certain circumstances, but I am not very happy at the proposal that you should charge a patient to go and see a GP.
I didn't suggest that as a proposal, just for clarification.
Right,
I suggested that if the Minister is thinking of that, then they need to work out the figures associated with it. And it may well be the case that it might, similar to what happens in the Republic of Ireland, generate some revenue. But if it acts as a deterrent to people to engage with the health service in a timely fashion, what you might in actual fact do is to incur greater cost, because they may be sicker and they may require more intensive and more expensive care when they do actually present. And I can give you examples from the area of cancer where that would be the case.
Okay, so you're not advocating.
No.
Okay, that clarifies it.
Yeah, I mean, I think that the point was being made that when we drilled down into areas of income generation, there were none coming from the department. So I think the point has been made here. It's about whatever that might be, it would need to be tested and modelled.
Exactly.
Okay, Joanne next and then Nikki.
Thanks, Chair. Can I thank you for your briefing also? And I know the Chair touched on this, but I was concerned by your central finding that resources are distributed on a pro rata basis as well, with little evidence of strategic direction. That's very, very worrying. And certainly that's been backed up here by recent decisions. For me, obviously, supporting staff and personnel is key to any health service, but above all, it's imperative the patients are put first and their needs should be at the forefront of any budget decisions, otherwise patient care will suffer. And suppose we've seen that recently and the decisions that have been made here. Are patients being put first in other regions of the UK? What's your understanding of that?
I think it's very difficult to satisfactorily define what you mean by putting the patient first. Because, in a sense, it's a bit like motherhood and apple pie. Everyone's for it. You know, anyone arguing for an efficient distribution of resources will argue that that puts the patient first.
But decisions that affect that patient care, I'm thinking locally here, the decision on the Dalriada, you know, obviously we had the Permanent Secretary here, Richard McGall, a few weeks ago. I was trying to tease out of him. Patients, you know, looking after the patient has to be paramount in every decision, surely, going forward. If you get that right at the start, that has to be your strategic direction, surely.
And this is where we refer to the what we call the opportunity cost. If you're talking about putting one group of patients first, you have to bear in mind that there's another group of patients to whom the resources could be allocated to instead. And sometimes there are a very visible group that are impacted upon by a resource allocation decision, whereas there are a more diffuse group who are more difficult to identify, and the impact of resource allocation decisions upon them are more difficult to measure. I mean, I think in front of this committee in the past, one of the groups that would be where concerns would have been voiced would be those with mental health issues that is sometimes seen as a Cinderella service. And the issue about allocating resources towards acute care and what we would call big ticket items delivered in an acute setting is that you are taking resources away from another group who are more difficult to see, who may find it more difficult to have their needs represented.
Well, that's definitely a totally a valid point. But other regions in the UK, you know, what's your understanding of that with the patients coming first, or is it so obscure, so difficult to?
I confess I haven't looked at the resource allocation formula in other parts of the UK in some time, so I wouldn't be.
It just would be useful, Chair, to have that. In your conclusion, you say that publishing output and outcome data in the same way as England will allow productivity to be monitored. How does the publication of the data differ between here and England?
For example, here the data tends to be programmes of care, where it's different in England. There have been 4 major studies of productivity here and in England and in the wider UK. The results have been similar. But what I'm saying is that the actual formation of those data would be relatively straightforward. And just to have a data series, you know, is productivity increasing, or is the relative productivity decreasing between Ireland and England, or is it increasing? You know, those are general questions, but I think if you were looking at strategic issues, answers to those general questions, I think, are of interest.
And obviously it would be so much better to compare like for like, as you said.
Yeah, essential.
Some work has been done recently by Bevan et al., which follows up work done by Conley and others, which emanates from, hopefully I'll get this right, Nuffield Trust in England, which looks at mortality amenable to medicine, as it were, and does show improvements in Northern Ireland over time. So it's not all doom and gloom. Things are getting better. But to simply assume that that'll continue isn't necessarily the case.
How big is the gap then between our service performance here when compared to England?
It varies depending on which type of service you're actually talking about, and again, this goes to the production of a more comprehensive and longer time series, which would allow you to make those sorts of comparisons. So, for example, in some of the work they talk about the cost per particular type, but what they've done is to make comparisons where the data is available, and whether or not that provides you with a good enough picture, I don't know.
Thank you. Thanks, Chair.
Thank you, Joanne. Mickey, next.
Thanks very much for the presentation. Just to go back to a point of Kieran's, I know you were not advocating GPs' charges. It's a discussion, but it's such an emotive subject because ultimately, for many people, it undermines the ethos of the National Health Service. And I think if you look at the successive British governments, seem intent on eroding that. And certainly the current government, in terms of, I suppose, the National Health Service being one of the last bastions of socialism, do seem intent on privatising it. It's the same with the welfare system in terms of benefits and that. They seem very intent on that. So for a lot of people, the whole ethos of the National Health Service is very much being undermined with lack of investment. Because I remember one of the things that struck me, and when the first Gulf War happened, I remember Norman Lamont, I think was a British Chancellor at the time, being asked by a reporter, how much is the war going to cost? And he said there is a blank cheque for the war. I've never heard that said about health or education. This is just an interesting aside, I suppose. The other thing, transforming your care, when the RCN were before the committee, I think last year, they said that transforming your care was a vision without action, because the shift left simply hasn't happened the way it should have happened, because the infrastructure, if you're going to keep people in the community, you have to have that infrastructure in place. That simply hasn't happened. The 83 million or whatever was mooted at the time really has not happened, because there's been no will, in my view, to do that. One of the other issues was the integrated care centres. I mean, I live in Newry, I represent Newry Armagh constituency. We were supposed to have an integrated care centre to take the pressure off the acute hospital in Daisy Hill. That simply hasn't happened. There's been talking and talking about it. Nothing's really happened. Business plans in place and all of that. And revenue generation, there's a huge potential for revenue generation cross-border. Because if you take Daisy Hill in the renal unit, which is a very successful renal unit, there are 6 beds reserved for patients from North Louth, for instance, for dialysis. It saves them a lot of time and trouble around having to travel to Dublin. They can be in Newry and home by lunchtime, whereas previously they spent the whole day. There's much more potential for that. And in A&E, I think 3 years ago, we had something like 35,500 patients through A&E in Daisy Hill. 3,500 were from the south. So there is much more potential for revenue generation, which really hasn't been looked at in the round, I think. And so that the other thing is the whole issue around generic drugs. Because I know when I came on the committee in 2008, there was a practice in Castlederg, I think, had done a 6-week experiment using only generic, or prescribing only generic drugs, which saved something like 312,000 for that year. So there's huge potential there as well. But again, the difficulty is facing up to the drug companies, I suppose, because there's patents and all of that. But revenue generation is an interesting one, I think, because what's happening in our constituency is there's a realignment of Daisy Hill and Craigavon and a kind of rationalisation in terms of the stroke unit, where Daisy Hill is an extremely good model of good practice for thrombolysis and all of that. The average stay for a stroke patient in Daisy Hill was 17 days, in Craigavon 47 days, and yet it's being moved. Reablement and rehabilitation is being moved. So it just seems to happen without forethought or, thinking about what might happen to patients, because ultimately paramount in all of this is the patient. And I think sometimes that's the economics. There's a lot of cost, or a lot of talk about the economic cost, but sometimes not so much about the human cost. I think maybe that's something. And I know from your point of view, you're looking at it from a very academic viewpoint.
Well, again, one of the things that we would tend to do is to look at, whenever we're talking about economic costs, what we would argue is that you look at things in a wider or a more societal perspective, so that you don't focus in on what might give you a false economy. So you don't do, for example, to go back to the example of charging for GP services, you don't do something because it's convenient, because it's expedient and costs you money then down the line. So that's where it goes back to this issue of strategy, that things need to be looked at and the interconnections between them need to be looked at. If you change something with respect to access to screening services, what impact does that then have upon diagnostic services and treatment services? Look at it in the round, or indeed where you're actually going to provide services. So I would, I would
Thank you.
concur with you.
Thank you, Michael. Michael?
Okay, thanks, Chair. Thanks, Pat and Kieran. And we do a lot of talk around these issues, I know. So, and I can assure you, I did a lot of talk and a lot of effort around them. Can I make it just a couple of points? And your comment, and certainly as far as the generic drugs are concerned, we had a policy in my day, and it's still there, called Go Generic. And in 2008, the year that Mickey's referring to, a Dr. Norman Morrow, in charge of pharmacy in the department, produced 80 million in savings in 1 year. What you're talking about is part of that Go Generic policy that we had in place. And I had to produce 700 million of efficiencies, and Norman produced 80 million in 1 year. And he should have got an knighthood for it, but he didn't. There you are. But there's a finite limit to as far as you can go with generics. As you know, a drug is protected for the first 10 years. If you're 100% generic, it means you can't touch drugs that have been invented in the last 10 years, and you can see the sort of effect that would have. So therefore, there is a limit to where you can go, and I think the department, when I left, was somewhere around 71% generic. The target was somewhere in the late 70s, if we can get there. Bearing in mind, you've got to persuade the GPs to write the prescriptions. You don't get a prescription without a GP writing it. The GP writes it on the basis that you need that particular drug. And as you're also aware, generics are slightly different from the patented medicine, and you will get different reactions from a generic that you won't get perhaps from the patented medicine. Have you any sense of where you think that balance is? Because that was always an argument or a discussion, how high we could get the generic level in effect, because the drugs budget's running at 400 million odd prescriptions and 100 million through hospitals. We can control the hospitals, but you rely on the GPs to do the business as far as the prescriptions are concerned. Can I also just say, in passing those prescription charges, 90% of all prescriptions went free in my day when I looked at it, and we were then putting cancer onto the tariffs because it wasn't included as far as a tariff for free. And when you did that, we were up around 93 or 94% free. So that's why, in fact, I financed that out of my own budget, because there were 7 million in admin costs, 7 million in fraud. We were virtually, and I'd say it was cost, it wasn't, but it was very close to it. It was about 7 million, I think, as memory serves. So prescription charges, you would have to have a different, if you're going to get money in the prescription charges, you're going to have a different approach to tariffs. So babies get free, children get free, adolescents get free, pensioners get free, long-term sick, long-term conditions get free, unemployed and so on. You're going to have to look at something different there. You're going to have to take some of those off the list if you want to produce money. You can means test it, but that would throw the admin costs way up. I'm just saying it because there are no easy answers to this. If somebody presents to the GP and says a mill, the doctor can't very well say, well, give us 50 quid and I'll tell you what's wrong with you. It's that we have a different, totally different approach to medicine from, say, the States, for example. But you're right in one point, the key point you're making, and that is too many acute hospitals, too many facilities. And we all love our facilities, and why shouldn't we? Because they're doing a really good job for us, despite the problems we're in now. Health Service is still producing. How do you persuade folks that the local hospital, Bangor, minor injuries,
Darren, yeah.
yeah, well, The answer to that, it seems to me, is you invest in the Ulster Hospital and you produce an A&E that really is doing the business, so that people will bypass Bangor to go to the Ulster. And similarly with ours, it's got to be that sort of approach. So it's like an invest to save. You have to invest to get what you want. You have to have modern buildings, modern equipment, invest in the staff. It's the oneness formula, the Albert Oneness formula all over again. And that was basically the overarching principle that I followed. So it's the key element is the community engagement. You hear Mickey talking about Daisy Hill, but I mean Daisy Hill. If I was in Newry, I would want to go to Craigavon for a lot of the services because it's the big acute. You know, so it's how do we persuade Mickey that Daisy Hill is not his key acute, it's Craigavon. How do we persuade Kieran that his key acute is the Ulster and the bypass Bangor Newtownards? And that's the argument always, it's money. And I don't think money is the one to do it, you know. So I'd just be interested in your views on it, because every time I see all hell broke loose when I was there, as you're aware, and there was huge political pressure, and we ended up with a budget that I explained in 2011 couldn't do it. The health service is what it is, and it costs a certain amount of money to run it. Now, you may say it needs fixed, it needs change, it needs other, and we try to do these things, but there is a level of service there that requires a level of resource, and the Assembly wouldn't vote for it. And Sinn Féin, DUP and the Alliance voted down the health budget. And effectively, that's where a lot of our problems are now. So how do you persuade people? If you want the health service you've got to pay for it. If you want to get the money down so you have money for other things, those sort of changes have to be made.
I'm minded of a quote, I think it was by Adlai Stevenson, but I could be wrong in this, so apologies. You're entitled to your opinion, but not to your own opinion, but not to your own facts. One of the central things that we've said is that there exists information, or there should exist information, that should inform decisions, or at least why decisions are being taken, whether or not they're popular or unpopular. And I think that that information exists and should be used to better effect. So in relation to, for example, generics, there must be a disagreement between the department and the audit office as to what the potential savings are. Let them explore it, let them resolve it, let one or two of them come out right as to what the actual figures are. Similarly, in relation to prescription charges, if they are going to be introduced, you can go to the BSO and analyse the data to see what impact the removal of prescription charges have had upon use. My understanding is that they haven't had a material impact upon use.
And there was no latent surge. That was the big concern I had. There was no latent surge, yeah.
But the point is then that it's possible. The difficulty is asking the right question. The information is there to answer the question. If you get the questions right, you'll get the answers. And then there's the issue about how do you actually convey that to the public or to other elected representatives or to...
I would say that, yeah, that's right, but your pharmacy budget generics, you're talking 19 to 73. And I would suggest it'd be probably closer to 19 than 73, just from my experience, but I might be wrong. Yes, it's worth asking the question, but I don't see that would be part of the answer. There's a bigger answer in all of this. And around, we called it shift left in my day, it's now called TYC, and there is an element of that in it, and it's an element away from acute hospitals, and there's an element around public health and then depressing demand in a generation's time and so on. But the money is not going to wait around all that time. You know, you can see, and you can see where we are now. Jim all of a sudden has to find 75 million in-year cash. Virtually impossible. I get nailed for 300 million in-year cash in 2010-11 that nearly killed us. And you can see what's happening now. So ask the questions, get the facts, all the rest of it. But I think what we need is some of the answers.
I think as well, if I could just comment on that, I mean, the policy direction is set. You know, the policy direction in terms of transforming your care has been agreed to in relation to that shift left, and part of that conversation was about the amount of what was called then hospital networks that were required. The difficulty has been that the policy direction now hasn't been underpinned by any kind of strategic outcome-based framework that tells us, you know, if we shift this 83 million left, it will have A, B or C outcome. And that's where you know, the data is poor, and that's where there is no measurement tool to give confidence in the system. So, you know, in essence, the policy is in place. Michael, on this, was it?
Just the point Michael made, I mean, I accept we are all very parochial and protective about our hospitals, but the interesting thing, one of the big arguments around the Brooklyn and Daisy Hill, the move, is about transport for families. Because unless you have a proper public transport infrastructure from Newry to Craigavon, then therein lies a difficulty, because part of the argument is the patient's traumatised, obviously, so is the family, and the patient needs that support, so people can actually get from point A to B. And it's interesting, that's outside the medical aspect or the health aspect in a sense. So there's an overarching issue there with DRD and health about the provision of public transport, which is becoming even more compounded by the cut in the budget for DRD, where bus services are actually being cut. That compounds the problem. So just to make that point, and you know, we are very protective and parochial about our hospitals, and you know, and Kieran made the point, it's the kiss of death, literally, to suggest that your local hospital may be in danger of closing. Daisy Hill, thankfully, is doing very well, and there's been a lot of investment, and the current minister's put a further investment in about a specialist paediatric unit, which is welcomed. But it is a transportation problem as well for people. So it's not just about the medical aspect.
Paula, she indicated.
It's just a quick point. If you look at the figures for 2007, 2008, under the programmes of care, the care of the elderly is the largest after acute. And then I look at your review, your 2012 review here, and I see that Northern Ireland, it's stating here that Northern Ireland has the highest population, or the highest amount of people compared to England that are in care homes and are being looked after long-term in care homes, and yet Northern Ireland also has the highest level of domiciliary care as well compared to England. How does that equate, or how have we come to that we provide more long-term care in care homes and we also provide more domiciliary care? I would have thought it would have been one or the other and not both. Are we a different culture here in how we care for our elderly long-term, or...?
I mean, I must admit that I would be speculating, but I can speculate in the sense that if we have an abundant supply of care home, or what might be considered to be an abundant supply of care homes, then we'll use the care homes. Not dissimilar to the argument about acute care. If we have those facilities, we'll use those facilities.
But yet we still have a higher domiciliary care usage than they have in England, according...
Two of them aren't necessarily mutually exclusive.
You know, yeah. It's just I come from that background. That's the job I did a few years ago, and it's trying to. I mean, always the ethos was that you went home, you were cared for in your own home. And we did that 9 times out of 10, rather than place anyone in a care home. But it's just, when you look at the figures, it just seems quite strange that we have the highest in both. Is any other reason other than we have more care homes than they have in mainland UK?
I would need to look at the,
it's
at the
just
evidence
very
and think a bit more
strange.
about it.
You know, and if it is still one of our higher funded programmes of care, you know, the reasoning behind that, is it because of that as well?
We would have higher demand too, I think. And I think also there's a substantial private sector in England. People simply buy what they want.
Yeah, but do we have a higher population of people living longer in Northern Ireland than they do in the rest of the
Unfortunately, we
United
have a
Kingdom?
higher
Yes.
elderly population, also a higher younger population.
Yeah.
Yeah.
Unfortunately.
Okay.
People are living longer, but not necessarily more healthily.
Yep, understand that. And through you again, Chair, just one more question. So, have your findings? Have you found then that we care for our elderly differently?
We didn't investigate
No, yeah.
care of the elderly specifically.
No, I know.
So it would take
It's
us
just the
beyond
figures
area that
are just quite startling, because I would have thought in Northern Ireland our culture very much is that we care for our families. And someone from a social work background who met many families, and that was very much how people preferred to do it. There were great support. Families offered the support. I know, coming from a family in Belfast, that's how we care for our elderly. We care for them in our homes. We look after them. It just seems quite strange that is it a cultural? Are we different in any way? You know, that we use such a high use of care homes. Interesting. Thank you.
Okay, thank you.
Chair.
Okay, folks, thank you both. I mean, it's been saying a lot of things that we've been saying throughout the course of our deliberations around the budget. I think particularly, you know, the message that I take out of this is, I suppose, even your use of language when you talk about the recent evidence session with the Minister and the terminology that, or the response that strategic planning will be more for the future. Are we making logical decisions? We are not. We are making practical decisions on which we can deliver. And you'd actually refer to the fact that to propose a dichotomy between logic and thus strategy and practice is disturbing. You know, and I think it's our duty to take note of that terminology. I think equally the message, Pat, and I think it was yourself referred to it about, you know, the classic bureaucracy model. And I think that is an issue within health currently, about the various tiers of decision-making processes between the delivery of services, the commissioning of services, and, you know, the wider world looking in at this system looks at the department, the Minister, and then the commissioning groups, the Health and Social Care Board, the trusts, the Business Service Organisation, and decisions seem to go round the system. And the very point that you made about decision making needs to be pushed further down the line. You know, I think it's certainly a view that I would share anyway. As chair, I can't obviously speak on behalf of all of the members, and I also think it does bring in an interesting conversation about the policy direction, the number of hospitals, the potential better health outcomes that you can have as a response of taking those tough decisions as well too, and the very real debate about competition in the system versus, you know, opening up to market forces. So I thank you for that, and I think it would be also useful, Kieran, if you could share that paper you referred to about the health inequalities. I think it was work that was completed in England, because the committee are taking an active look at that in relation to Scotland. So certainly we welcome those.
I can forward those on through the secretary.
Yes.
Committee.
Thank you very much.
Thank you.
Thank you.
Thanks.
Okay, members. Moving on to item 5 is the review of the department's benefits management framework and the briefing by the expert advisor. Page 135 of the meeting folder for the relevant papers. Further information which has been supplied from the department. Advising members that Anne Watts, who is the expert advisor appointed by the committee on the benefits management framework for Transforming Your Care, is here. Is here, I hope, yes, today to present a report. We'll just give her a minute. Hello, there you go. And thank you for taking the time to do this work and for attending today as well. And what's from the Change Emporium. So we're going to ask you to maybe to address the committee present your findings, and then we'll just open it up to questions from the members.
Okay, fine, thank you. First of all, thank you for leaving me the opportunity to come here. A bit windy outside, but hopefully I can provide you with some updates and reviews. Now, what I was asked to do, as you have in front of you, is a report, a review of the benefit realisation framework associated with the Transforming Your Care programme. To be entirely honest, the time that was allotted to actually do a really good review was very, very short. And I've tried to sort of caveat that in the context of the setting at the first beginning part of the report. The documentation that I was originally provided was quite detailed, but not detailed enough for me to be able to do the level or the quality of response that I felt was appropriate to give you the real assurance and evidence in terms of the maturity of the framework, and also to position it in such a way that it was able to be understood by people who perhaps haven't got a lot of experience in the field of programme project management or indeed benefit realisation. So hopefully the report is broken down in a very sort of simple way, but more based on the evidence, on the documentation that I was able to provide, was given. Because of the initial documentation, I approached Marie Austin in the committee office to actually help me to try and identify some of the gaps that I felt were missing. What I didn't want to do was to produce a report based on the initial documentation, purely because I felt there were too many gaps. And for such a large, complex programme that's been going for a number of years, I didn't feel that that was appropriate. So I reached out to the Department of Health and Social Care and had a telephone conference with them at some length to try and explore some of the questions that I had that Marie and her colleagues were unable to answer. I think, if I can be quite honest, it was, unless you actually know the right questions to ask, it's difficult to know what responses you're likely to get back. Hence the reason why I felt it was appropriate to have that conversation. And through that process, I was able to pose a number of challenges and questions that allowed me to explore a bit deeper in terms of what the framework was actually involving, how it was constituted, how robust it was, and also to ask to be given more documentation to allow me to produce a fairly sort of light report, but one that expanded beyond just the theory of what benefit realisation framework was, but just to really provide some substance and, more importantly, the evidence that I feel was needed in order to demonstrate that they had an effective and efficient framework in place. So the report is literally laid out, taken into account the documentation that I read, taken into account the conversation that I had with the department and a number of email exchanges following that meeting with a number of people from the department that allowed me to pull together all of the responses that I was requested in terms of reference from the committee. The summary of challenges are literally what I'm positioning are challenges. I don't want to be critical of the framework because, in essence, when you look at the framework, it is a fairly robust framework based on the fact that the programme is an extremely large programme, complex in terms of its dynamic spread across a number of key stakeholders across a different geographic remit. One of the biggest challenges I had was being able to really see if the framework, I could stress test it, and the only way you can do that is to actually sit down and talk to people and to really start to understand how the framework was being used in the context of the regional plans, how all of the stakeholders were actually ensuring that all of the detail that they had within the business cases were able to support the outcomes and the priorities and the objectives that were related to the Transforming Your Care programme. So I've taken account of, as I say, the evidence that was provided with me to a point that I was able to. Some of the evidence was not available. Fundamentally, one of my first challenges is that the benefit realisation strategy is still being debated and hasn't yet been finalised. So that in itself, together with my findings based on the 14 challenges that I'm presenting here, rather provides the evidence of a level of immaturity around the approach to benefit realisation being applied Having said that, the structure of the team that is trying to drive this forward and the focus of them understanding the basic fundamentals is quite strong. I think it is literally a matter of a level of maturity that really allows these challenges to be fed back into the department for them to help evolve their framework to a point where you would be able to have more evidence. So the report itself is a summation really of that evidence to provide best practice, to give some demonstration of best practice. And I've tried to put in there a number of examples from other health authorities and within the UK and outside of the UK, but mainly within the UK, having worked for 3 other foundation trusts putting in place a benefits management framework. I'm very familiar with the complexities of how it's difficult to let's say, identify how do you quantify reducing a length of stay, where do you start and where do you end. So it's not an easy task. So I hope that sort of gives some context to where I was able to put the detail in the report. And I think what would be most helpful is to provide you with some further sort of articulation around why I'm posing these challenges and then how, more importantly, you want to feed those challenges back into the department.
Okay, and thank you very much. And, you know, firstly, can I say that we acknowledge the time constraints that you were under to do this piece of work, but it's probably important to say as well that for us, this was about, in terms of our scrutiny role, trying to drill down and really scrutinise and understand the framework that is required for the Transforming Your Care policy and Shift Left. And, you know, when the concept of a benefits management framework was being alluded to, this committee wanted to understand that. And I mean, I have to say that just looking through your report, you're identifying similar problems in terms of omissions and gaps that we have identified ourselves as a committee. And you know, the failure to monitor, I think, is a critical, particularly in terms of even monitor baselines.
Yeah,
is of a concern. And I suppose the whole issue in relation to health inequality. Then, how will this policy direction monitor health inequalities and provide better outcomes? So, I suppose my question would be, and I know that I think it's in the region of 14 challenges there, and you know what I would suggest, and would seek agreement on this, but this committee should share those with the department and ask for a response to each of them with a timeline.
Yeah, absolutely. I mean, forgive me, I took my terms of reference to be quite literal in the sense that I haven't, as you'll see, not put forward any recommendations. Purely because, as I say, I feel that the level of maturity is still evolving, and that's the reason why I tried to reach out to them and get further documentation to provide me with further evidence as to just how far down the line are they. The challenges obviously can be interpreted as recommendations, and in some ways they are. And I think to go back to the department and certainly ask for further evidence of the actual strategy itself, because the programme consists of so many different types of projects, the whole level of complexity in terms of how do you demonstrate that what's happening in the regional plans is actually going to make a difference into the health equalities in Northern Ireland, something that you need to have evidence-based. So one of the key areas for me in terms of the monitoring and the reporting, I felt that there wasn't enough evidence to provide this committee with assurance that actually what is being done within the regions in terms of the projects and what they're trying to drive was evidence-based, because I couldn't see any evidence of it, but it may be there, and I think that's the further exploration that you would need to have with the department themselves, and it could take, you know, a number of days to really get to some real examples of taking a number of projects in a number of the different regions and looking at the depth of what they're trying to drive out regionally, and then looking at the programme and seeing how those two align because I didn't have the documentation to be able to do that. So I hope in the number of challenges, and I think the original documentation omitted on one of the challenges is 13 and 12 around the wrong way, so my apologies on that part. But there are some, I believe, some basic fundamental omissions, and again, it could be purely because I wasn't able to either have sight of all of the documentation, maybe because of the time constraints, or simply maybe because of protocol, or indeed simply because they haven't got to that level of maturity to be able to provide it. So to have a plan of how you're going to realise the benefits, actually identifying what the benefits are and how you're going to make improvements in each of the areas of the inequalities. I couldn't find any actual metrics. It was very woolly and narratively rather than statistically based, and certainly not financially based. And when you've got a 5% challenge in your shift left, I felt that was something that I feel needed to be explored further. And the complete omission around what I'm terming as a disbenefit, and unfortunately it's not in the dictionary, but it does exist in terms of a benefits management approach. There is no mention of any disbenefits at all, so no emphasis of anything that is negative in the sense of actually something that might not always be to the advantage of a key stakeholder, and also some of the challenges around how they're monitoring and tracking, and the fact of how that's being supported and scrutinised at the level of detail from somebody that really understands what benefit realisation is. Certainly the PMO that I had the opportunity to talk to understood the basics, but I did feel that, again, based on their level of maturity, they do need an extra support to be able to be either challenged or to be fed back to actually sort of help them evolve it and develop it accordingly.
I mean, I think I suppose what's of concern in that as well is that we have a process which effectively is 3 years old.
Yeah.
In terms of that shift left, and clearly what you're saying today is the committee's sense that it hasn't been underpinned by that management outcome-based framework at all.
Yeah, I think in defence of where everybody is for a period of 3 years, it's not uncommon for organisations, whether it's in a health setting or even outside of the health in private sector. It is quite a common failure of organisations to do benefit realisation at the back end of the process. If you were to Google or to actually look at even some of the best practice OGC, the Office of Government and Commerce, which actually doesn't exist anymore, but in terms of what they put up and what they've documented in the department's framework, it is still all for challenge. And right at the end, they have a little component that says, we'll set the project up, we'll understand what we're trying to deliver, we'll put all the policies and processes in place, we'll start to deliver and implement, and then we'll do benefit realisation. And this is the biggest failing of many organisations of all sizes, that they leave it to the last end, which means that they end up delivering, making all the changes, and then desperately trying to retrofit what the benefits are, which somehow tends to give the wrong conception around what they're trying to achieve in the first place.
And I think it also makes the system feel as if you're staggering from one crisis to another,
Yep.
and that it's not instilling the very vital outcomes and public confidence, I think, that is required in the system. But specifically, Anne, as well, you referred to the Outpatients Reform Project, I think it was called.
Yes,
and
that's
the
one
aim
example.
to make savings by reducing what was called DNA, which did not attend rates.
Yep.
And all our evidence that we've looked at, we can see that the DNA rates were higher in more disadvantaged, deprived communities, and so a project which encouraged and facilitated attendance might help to reduce health inequalities, I suppose, which is a big focus of our work. And then on the other hand, you had a project which penalised patients whose DNA by simply cancelling their referral, and it could make health inequalities even worse. So I suppose my question is, did you see any evidence that the analysis of TYC benefits will, I suppose, tease out the importance of outpatients reform in terms of the health inequality? Did you see any evidence in that?
No, I didn't. And as I say, that could be for a number of reasons, because I didn't have the opportunity to be given that level of information. So that's not to say it doesn't exist, but certainly I struggle to find the evidence, hence the reason why I put the challenge down as to how confident would you be in really understanding that there is a shift that helps to reduce or to improve in those areas, whether it's efficiency, whether it's cost base, whatever it is. And that's the level of detail that I would certainly recommend through these number of challenges that the committee explores with them in a lot more depth. Because I think there is, again, experience from my part working with so many different organisations, is that there is another failing, which is around reporting and tracking the most important measures, where they have 16 outcomes and therefore they have 16 what they call profiles. Within that profile is quite a lot of detail, but it's missing quite a lot of detail as well. And all I'm seeing is a profile that shows the combination and the collectiveness of how you're going to drive out an outcome without a figure associated with it or without a performance indicator. Some didn't. I only had one example that was provided to me. But there was nothing that I could benchmark against how each of the individual projects was going to contribute to that, and therefore where the lower detail was around how you're measuring to give the evidence of the changes that were being put in place.
Well, listen, that's nobody else had indicated at this point. Very, very useful, Anne, and I do want to thank you for taking the time up to this point. I think this is a conversation that needs to continue. Certainly, I would propose that the challenges that you have identified in the report are sent to the department with a request for a response to each of them, and I would suggest a timeline attached to that, and I would hope, Anne, that when we get those responses, and that we could maybe look at the opportunity of sharing those with you again, and maybe continuing in some format the conversation as the next steps. But it's certainly been useful. It certainly validated some of our thinking around the performance monitor, the omissions, the gaps, and a system that is coming in at the end of a policy direction to, put in place a management framework in terms of outcomes. So can I thank you for that? And if you're content, we will share those challenges with the department and seek their responses and share them with you.
No, absolutely. I'd be very delighted to do that. And I did, when I had the conversation with the department, express some of the sort of concerns in some of the gaps, and by their own admission, they would be very open to extra support and challenge. So by that nature, I think that would sort of be coming together of like minds in order to recognise the level of immaturity of their framework going forward, and perhaps at a time when we have an opportunity to influence some improvements at the right space. One of the areas that, forgive me if I just show something to you, if I may, is that okay?
Sure, yeah.
If you look in the documentation, and I accept that it's quite small, but there's an important concept which is around mapping, and the way that the department has actually produced it is on page 30. You have what they've termed as an outcome map. And I had a real fundamental challenge in the use of definition between an outcome and a benefit. And forgive me, whilst I don't want to sort of turn this session into an education session, there is a really important difference between the two. And even whilst they're using the OGC as a benchmark for best practice, that has evolved over many, many years. And I think they just perhaps need to be influenced to really challenge their own thinking, because this outcome map demonstrates nothing other than its relationship to the objective and the project and the outcome. There's nothing in there that says what change needs to be brought about, and there's nothing in there to demonstrate the difference between the benefits and the outcome. And if I show you an example of another, this is forgive me because I've just brought it with me. This is a visual dependency map. It's colour-coded because it shows you the difference between what is a benefit, what is an outcome, what is a project, which is yellow, to deliver something, leading to the objectives over here, which is blue. And visually, this turns into a very powerful form of communication it also turns into an ability to manage risk more effectively. Plus, it also provides an ability to help plan and break down into phases. And when I looked at it, this is the sort of level of detail that I would be expecting. And this is not something that I've sort of brought up here as an example. This is a common dependency map that is well used within the NHS. If you go onto the Institute of the NHS, you will see that this is a framework of a benefit dependency map within that. So I think this is another way to actually help them bring and demonstrate to the committee how each of the local projects do actually contribute to the overarching 16 outcomes that meet the objectives. Because just simply looking at that, and when I asked the question, do you have any other visual maps to help me demonstrate that, there aren't any. The simple sort of challenge around utilising the tool, just simply by using PowerPoint or Visio. It doesn't need to be more complex than that, but the concept of what this is and how it brings everything together would provide me, from a specialist point of view, forgive me, I don't like to use the word expert because I think you can always learn things, but I think it would provide much more substance and credence behind how they're actually going to demonstrate all of the projects are indeed contributing to all of the figures and ratios and percentages and savings that need to be driven out of meeting all of the equality priorities.
Okay, look, that again, very, very useful. I mean, I suppose from our point of view, again, this is about drilling down and understanding what this alleged management framework will do in terms of the eradication of health inequalities and providing better outcomes and instilling that public confidence in the shift left that is required to deliver better outcomes. So again, as I said, happy to share that with the department and seek their response within a time frame, and we will come back to you with that.
Chair,
Okay.
can I
Sure,
ask,
yes,
just in relation to, I think I know the answer, but do you think there's sufficient transparency and around how monies has been transferred from existing areas in the community-based investments in your work? I mean, it's a very detailed report, and we thank you for it, as the Chair has said, but do you think there's enough transparency in where how the money has been distributed from the community or into the community?
Okay, in response to that, and I think when I first started talking, I did put the caveat that I had limited exposure to documentation, so it may exist. In what I reviewed, I saw no evidence that demonstrated that transparency at a financial level at all.
We're worried about, absolutely. Yeah.
And that's not to say it doesn't exist. In the report, I've given a copy of what they call a benefit report and outcome, which alludes to a target, but I could not see anything that actually demonstrated a financial implication. But I think that's just something to perhaps go back and re-challenge them to say, show us what that is.
I think actually the last time we had them here, we had to force it out of them how much they spent in the last year in relation to this. So, you know, that answers my question.
Yeah, I think my other concern would be around the actual monthly report, which I've given an extract of a copy in there. I found that, again, not to actually state anything relating to benefits or outcomes, whether it's financial or non-financial. It was more a status report than it was of actually providing evidence of trajectory or meeting improvements from target base.
Thanks very much.
Okay, thank you for that, and we will continue to communicate once we get the response back from the department. Happy to share that with you then.
Okay, excellent.
Thank
Thank you
you
very
for
much.
your
Thanks for your time.
Thank you. Members, moving on to item 6, which is the January monitoring round, briefing by departmental officials, page 222 of the meeting folder for the relevant papers. We do have officials here today, yes, to outline the department's January monitoring round. Give them a minute.
Those are tasty wee things, aren't they? I tried.
Okay, we're just going to move on because the officials aren't here. I'm hoping they're en route, but they're not here yet. So I'll move on, members, to item 7, which is an SR number 277, the Food Hygiene Amendment Regulations 2014, page 238 for the relevant papers. We had considered and approved the SL1 for this rule on the 9th of April 2014. The Department has advised that the policy content has not changed since the SL1 was considered by the Committee, and the Examiner of Statutory Rules has no issues to raise. Can I ask, therefore, are members content with the statutory rule?
Agreed.
Okay, the Committee for Health, Social Services and Public Safety has considered SR 2014 number 277, the Food Hygiene Amendment Regulations, and has no objection to the rule. Agreed. Item 8 is SR 2014 number 285, which is the Products Containing Meat, etc. Regulations 2014, page 250 for the papers. We again had considered and approved the SL1 for this rule at our meeting on the 29th of January 2014. Again, the Department has advised that the policy content has not changed, and the SL1 was considered obviously by the Committee and the Examiner of Statutory Rules, and there's no issues to raise. Are members content?
Agreed.
The Committee for Health, Social Services and Public Safety has considered SR 2014 number 285, the Products Containing Meat, etc. regulations, and has no objection to the rule. Item 9 is a Food Hygiene and Official Feed and Food Controls Regulation 2014, 273 for the relevant papers. Again, we had considered and approved the SL1 for this rule at our meeting on the 10th of September 2014. The Department has advised that the policy content has not changed since the SL1 was considered, and the Examiner of Statutory Rules has no issues to raise. Were members content?
Yep. Agreed.
Therefore, the Committee for Health, Social Services and Public Safety has considered SR 2014 number 286, the Food Hygiene and Official Feed and Food Controls Regulations, and has no objection to the rule. Item 10 is SR 2014-287, which is the Fish Labelling Amendment Regulations 2014. It's on page 283. Again, we had considered and approved the SL1 at our 10th of September meeting 2014. The Department has advised that the policy content again has not changed since the SL1 was considered by the Committee, and the Examiner of Statutory Rules has no issues to raise. Are members therefore content with the statutory rule?
Agreed.
Therefore, the Committee for Health, Social Services and Public Safety has considered SR 2014-287, the Fish Labelling Amendment Regulations, and has no objection to the rule. The next item is another SR 2014 number 288, which is the Misuse of Drugs Amendment number 4 Regulations, page 293. The relevant papers. Again, we had considered and approved the SL1. The Department has advised that the policy content has not changed, and the Examiner of Statutory Rules has no issues to raise. Are members content?
Agreed.
Therefore, the Committee for Health, Social Services and Public Safety has considered SR 2014 number 288, the Misuse of Drugs Regulations, and has no objections to the rule. Item 12 is an SL1, the Health and Social Care Bodies Membership Regulations. Just advising members that the Department is proposing to make a statutory rule to amend a number of regulations to provide that the chairs of the Health and Social Care Board, the Public Health Agency and the Business Service Organisation are disqualified for appointment on the same basis as other members appointed to these bodies by the Department. Informing members that a consultation on the draft regulations was carried out earlier this year. One response was received which supported the regulations. So are members content that the Department makes a statutory rule?
Yep. Agreed.
Okay, I think the officials are here now, so we'll bring them in at this point. Folks, you're very welcome. Julie Thompson, Deputy Secretary, Resources and Performance Management Group at the Department, Jackie Johnson, Director of Secondary Care at the Department, and Bill Pauly, Investment Director. I'm going to ask you to make your opening remarks. Julie, I'm assuming you'll take the lead on this.
Absolutely. Yes, and we provided the committee with a briefing paper, so thank you for the opportunity to provide evidence to the committee today on our approach for both capital and current expenditure for the January monitoring round. In terms of current expenditure, we've considered a range of factors, the most significant of which continues to be the financial context for 14-15. Members are fully aware that the £80 million received in June and October monitoring rounds did not fully address the full scale of pressures in 14-15, and that a range of measures have been implemented right across the Department and its ALBs in order to constrain expenditure where it is possible to do so. However, it's also acknowledged that the availability of funding in this monitoring round is likely to be very limited in light of the wider constrained funding environment and the pressures being experienced by all departments. Given where we are at, the Minister's view is that bids should be submitted in the January monitoring round. The bids need to reflect areas where funding can realistically be spent before the end of March 2015, which is a key requirement for the utilisation of in-year monitoring funding. And in that context, we're proposing to make 2 revenue bids. £10 million is proposed to be bid for to be allocated to trusts to provide further assistance in minimising the impact of their contingency plan proposals and providing support to the provision of domiciliary care and unscheduled care through the remainder of the winter period. A further £13 million would be used to deliver additional elective care capacity across a range of specialties. It is anticipated that this level of funding would enable 4,000 inpatient and day case treatments for those patients currently paused in the independent sector, and would also allow a further 7,500 patients to benefit from reduced diagnostic waiting times, whilst 4,700 new outpatient assessments and 900 inpatient day case treatments could also be delivered by the trusts. Members will note that these bids have also been prioritised in line with DFP requirements.
Chair, could I ask, do we have got a record of those?
Yes, it's all within the briefing paper.
All right, okay.
Yes. Turning to capital expenditure, we have surrendered some £5 million related to financial transactions capital for a scheme for GPs and dentists, as expenditure will not be incurred in 14-15 and it cannot be reutilised within the department. We have submitted a bid of £5 million for a range of issues, including the purchase of medical equipment, addressing minor works, improving the clinical environment, improving transport and addressing ICT needs. And we have also submitted a bid to retain additional asset disposal receipts of £1 million, which will provide increased spending power for the department. In conclusion, we would strongly recommend that the department's bids are considered favourably by the committee, and we are of course happy to take questions from members.
Thank you, Julie. Just specifically in terms of the financial transactions capital issue, you refer in the paper about the scheme for GPs. Is that the health and social care campuses?
No, it was for a range of GP, more along the lines of GP minor schemes, if you like, that they would effectively have bid for and provided an element of support to them, but it wasn't for the GP infrastructure, primary care hubs and spokes, which I think that you're referring to. I don't know whether, Bill, maybe you want to add anything further to that.
No, it's relatively small loans that would be secured on the premises that the GPs wish to improve, and that they would pay back the loans through that in relation to that. And the scheme opened on the 1st of December when the board issued all of the necessary paperwork to GPs, and we're awaiting their applications now, which won't return in time for the money that we have in this year to be spent.
So there will be £5 million that will be returned, is that?
Yes, there was £2.5 million for a GP scheme and there was £2.5 million for a scheme for dentists. The hoped-for scheme for dentists was slightly different in that it was, instead of going for premises, it was mainly designed initially. We had hoped to have a scheme that would help them buy equipment, where the equipment was of lesser value than the type of infrastructure that we had hoped that GPs would invest in. It hasn't been possible to bring forward a scheme for the dentist equipment, largely because there's been difficulty in meeting the Financial Conduct Authority regulations. The dentist loans were to be smaller, which meant that they were going to be unsecured, which created additional risks that would have had to be managed, and the Financial Conduct Authority has raised a number of questions and issues that preclude us from bringing forward that scheme within a year.
But could have been more planning or management of the scheme, do you think, in terms of from the department's perspective?
I think the complexity of financial transactions capital has surprised all of us, including those developing financial transactions capital schemes from other departments. The need for Financial Conduct Authority approval. In relation to the GP scheme, we've had to have a new legislative direction for the scheme. We've had to have loan agreements and put in place arrangements to receive the repayments of those loans over a period of up to 20 years, and also arrangements in which we would take security on the assets that we're making loans. And the complexity of small loan schemes has, I think, taken us longer than we had initially hoped for to put all of that in place.
But is there, I accept that, and I think it is a pattern across departments around the FTC processes, but what more can be done then?
We've been, I think to add to that, we've been working very much with both DFP and SIB around this and sharing our experiences and our learning in terms of the work that's been involved in this, because how FTC is then used in the future can maybe be better informed through that work. To be fair, the GP scheme is now up and running, as Bill said, and it's just a question of timing in terms of not being able to get the expenditure through in this year, but that money will be spent as we move forward into 15-16. Whereas the dentist scheme, unfortunately, that won't be taken ahead. But we're definitely working with the central parts of the system to share that learning so that FTC can be used in the future in a way that is maybe easier to use and that suits the projects more appropriately.
Was there some conversation taking place that FTC could actually be used as a lever as well for processes around the European Investment Bank funding? There's some conversations.
The Finance Minister did announce as part of the draft budget for next year his infrastructure fund, and I think he has some ambitions that FTC would form part of that fund, and also that the European Investment Bank, alongside possibly other private sector investors, would contribute to that fund. That would create a substantial fund with all of those quite large investments, to which people could apply and finance what would really be much larger investments. Our experience with the complexity of this scheme has related to the quite small loans among and across a large number of GPs, where I think everyone would now acknowledge that the larger investment projects of the type you mentioned might be more appropriate for what is a complex financing mechanism.
Okay, I think I had Kieran next.
Thanks, Chair. Thanks very much, Julie, for your presentation. You were going that hard. I really missed it, but I've got the stuff that you have here. And my concern is that, here we go again, almost, in that we're dependent largely on the monitoring grounds. January, and we're talking about, and I very much hope that something comes around, because particularly on the elective stuff that we're talking about. Is there anything that the department could have done a number of months ago to avoid having to have these pressures now at this particular time?
I guess that goes back to the overarching financial position, and the committee, I think, is well aware through several sessions on 14-15 that we came out of the October monitoring round some £70 million adrift of where we would have liked to have been. And we've been working hard at therefore trying to resolve that position as we look ahead. Equally, in terms of could more money be spent within that elective care area between the middle of January and the end of March, that is absolutely a possibility, and therefore the Minister thought it appropriate to bid to the centre for those funds, which would help people to get the treatments and across a range of procedures. I think, to be fair, the pressures within the centre part of the system, I wouldn't want to mislead the committee in the sense that there are significant pressures globally across the block in 14-15, and therefore whether these bids are successful will be a challenge as we look ahead into the results of January monitoring. But nonetheless, if money did become available, we absolutely could spend it, and I think the committee would view that as good expenditure in terms of being able to put to good use the money there. So that's the approach that we've gone down. Of course, we wouldn't want to be relying on in-year monitoring monies, but that's the scenario in which we're in.
Right, okay. And just finally, Chair, I'm looking at the consequences if transactions is not approved, and I'm particularly concerned about domiciliary care expenditure restrictions. The last time you were here, we were informed that I think it was 31 million out of the 80 million. There was a proportion of that to go to domiciliary care. What's happening there? Is that blowing already?
Out of that 31 million, I think as I advised the committee, there was £8 million set aside for domiciliary care. The simple fact of the matter is that we could spend more on domiciliary care packages between now and the end of the year and help to relieve some of the pressures that are out there in the system. And again, Minister took the view that therefore a bid was appropriate at this stage. That the trusts are under pressure, and I think part of the concern that you raised the last time was about the pressures within the domiciliary care packages, and that potentially we could do more. So we've absolutely raised it as something that we could put resources to and help therefore to alleviate the situation as we move forward, and we await to see what happens from that.
And even with that 8 million that you have received, you're still telling us that unless you get more, we're going to be restricted.
I think the member is well aware, if you like, that there's a lot of pressures across the system, and domiciliary care is one of the areas that trusts have had to look to see what can be done in terms of containing expenditure. If this bid was successful, it would allow that money effectively to be placed within the system.
But just, I must draw to your attention, and this is what I think said to the Minister on the floor yesterday, that if domiciliary care is cut further back, we're going to end up with more people looking for, probably and unfortunately, looking for admission to hospitals, and that's exactly what you're saying here.
And
so, it seems to be a contradiction in terms that you're not going to provide the extra funding for domiciliary care. You're prepared to take the risk of allowing people to enter the hospital.
We've allocated £8 million out of that October monitoring monies to domiciliary care, and we're working as far as we can to maximise the use of those resources and ensure that the maximum number of people can get the packages. What we can do is, if more money became available through monitoring, that we would be able to put more money into the area between now and the end of the year and help maybe alleviate pressures through the winter period. So we've invested what we can, but we are £70 million less available to us than what we would otherwise have wanted out of October monitoring. This effectively is saying we could absolutely spend £10 million in addressing some of those pressures as we look ahead to now and the end of the year.
All right, thank you.
Thank you, Kieran. Joanne, next.
Thank you, Chair. Can I also thank you for your briefing? Like Kieran, I'd like to start with elective care on the bid for £13 million. I note your request for £2.2 million to fund trusts to undertake additional, and it's underlined, in-house activity. Can you explain exactly? I know you've referred to 4,700 new OP assessment, 900 IPDC treatments. What these are, and how patients currently facing lengthening waiting times will benefit?
That's Jack, can you take that one?
Yeah, well, at the moment, as you know, we have an upward trend on the waiting times, particularly for first patient appointment and also for inpatient waiting times. The proposal for the £2.2 million would, as you were saying, help to provide additional in-house activity during February and March, because bearing in mind we'll not know the outcome of this monitoring round until January. And that would result in 4,700 new assessments. So that's diagnostics in terms of people waiting for diagnostics, and 900 inpatient day case treatments during February and March. And that we would hope would have some impact in the upward trend in the waiting times.
I note you have said that there has been rising from the end of June 2013. In-house is underlined. Why have you specified in-house activity rather than third-party private providers?
Well, we've separated it out in that we're suggesting there's currently 4,000 patients with the independent sector who've had their treatment paused since October of this year. So the bid has £9 million earmarked for that activity to try and get those people waiting before April starts. So the £1 million is aimed specifically at in-house and trust that we would increase the capacity in-house to deal with the other people waiting.
So specifically then, they will benefit quite early in February, March then?
February, March would be the plan, yeah.
Okay, can I refer to as well your request for the health service, what Microsoft software contract included in the monitoring round? Why is this included? I know you touched on this, Julie, one of the previous times you're up.
Yeah.
Why is it included in the monitoring round rather than accounted for within the budget? Because 3.25 million, it's not an insignificant sum of money. So can I ask then what negotiations have you entered in with Microsoft to ease the pressure of this amount? Surely there's such a significant amount, there's negotiations.
And I guess I can certainly make a start in that, maybe ask Bill to comment as well. You're absolutely right, we talked about this before in the context of October monitoring, and we made a bid at that stage of £12 million for ICT and a range of other pressures. Now, of that we got £4 million, so effectively we're coming back now to say we can still spend that £5 million if it were to become available at the block level. And our understanding, just to be clear about the distinction between the two, is that capital monies are likely to become available at the centre, and as our briefing sets out, we have advised DFP that we could take that £5 million. We will do our absolute utmost to spend that money between now and the end of the financial year, but there is a risk that we don't, but that's still viewed as better, if you like, than have it sitting at the centre and us not try and get the money spent. So we are caveating and warning a DFP that we may not be able to get the money fully spent between now and the end of the year, but we will do our utmost to do so. So that's kind of the positioning. So 12 million we bid before, we got 4, we're now going back looking for 5. And in terms of the actual processes involved, you'll be aware about obviously the need to have licences in place on ICT, and we'd looked about how that might happen. And I guess if maybe Bill, you could explain a bit about whether this would fall in this year or in next year was part of that debate.
I think starting with what negotiation has gone on, the actual procurement contract that this is bought under will be one that was put in place nationally through the Office of Government and Commerce. So,
no negotiation?
No, there was national level negotiation to put a contract across the UK so that we were a bigger customer, and that the deal that could be had with Microsoft, that we would be a larger customer dealing with a very large corporation. In terms of the deals that could be bought and the discounts that would apply compared to with a much smaller business for each individual licence that would apply within that. So it's been bought under that contract, and our understanding is that Office of Government Commerce contract expires in early April next year. So if we can purchase this in year, we will get discounts that apply under that contract, and there's no guarantee that those would be available whenever the national level arrangement for purchasing Microsoft products expires.
So it could be significantly more then?
The expectation is that prices, it's not so much that prices will go up, but that the discounts offered will not be as favourable as they are under the existing contract. We haven't yet seen the existing contract though, so I couldn't say for certain what that would be. In considering the business case for this expenditure, we did take central advice and worked with our colleagues in the Enterprise Shared Services and DFP in the approach to buying licences across the public sector in Northern Ireland, as well as for our arm's length bodies. And
that ends in April, and you don't know then the cost after April?
There has been significant discussions with Microsoft about the cost of this and what deal that we could get if we procure this now, as opposed to waiting to the next terms. But we haven't received, nor will we know for certain what exact deal they would give us next year. But we need licences, and a certain number of those to start the next financial year.
And I think if I could add to that, DFP have been very supportive of both the approach of the business case and the approach on procurement. And as already indicated, there is capital monies, as we understand it, available at the centre, and that's no guarantee that we will definitely get the money, but certainly the indications from DFP on this particular one have been very positive.
Thanks, Chair.
It's just on one of the points Joanne has raised there, in terms of the elective care issue, Jackie, it's probably yourself, but we're talking 13 million, 9 to the independent sector.
Yes.
Is it more expensive to the independent sector?
Well, it's down to the complexity of the condition, obviously, in terms of of patients that are paused out there at the moment. So it's difficult to sort of give you a definitive answer on that. You know, we're not sort of comparing like with like. It depends on the speciality, depends on the nature of the speciality in terms of the cost per patient, cost per treatment.
But we can calculate how many procedures could be carried out with the under 3 million that's left for in-house.
I think the issue around, the 9 million here is about patients who are ready. So this is about utilisation of money between now and the end of the year. These patients have been assessed and they're ready to have their inpatient and day case procedures. The capacity exists in the independent sector, and it's about, if you like, utilising that sector, the people that are there and how they've been assessed, and actually then processing them through in February and March, and that means that the money could be spent. So it's a combination of the conditions, the people, and then being able to spend the money between February and March. And these patients have already been assessed and are effectively ready to be treated on inpatient day cases within the independent sector.
I think as well, but if we can calculate again that the 3 million in terms of in-house will result in X amount of procedures, then we can do the same calculation for the 9 million, I would have assumed, in the independent sector. Therefore, there's your calculation.
It'll get down to the different types of procedures and what has actually been treated in which sector. But absolutely, we will know both the cost within the independent sector and both the cost within the in-house. But you won't necessarily be comparing like with like, because it's not necessarily the same procedures on both sides.
Can we have that information shared with the committee?
Yeah, we can ask for it. Yeah.
Okay. Thank you, Michael.
Right, thanks, Chair. I'm just basically trying to get my head around the sums. You're surrendering 5 and asking for 23. Is that right?
We're surrendering the surrender we're doing
not capital,
is capital. So on the capital side, we're surrendering 5 FTC. Or financial transactions capital, and we're asking back for £5 million of capital and £1 million of the assets receipts effectively that we've already or would anticipate that we can get. So that's the capital side. Yep. And on the revenue side, no surrenders and £23 million request. How
does that affect the 70-odd million pressure that we've been hearing about this last few weeks? Does that come off that?
In terms of the £70 million pressure, effectively the elective care would be, if you like, now able to be done that wasn't able to be done. So we, as Jackie's already pointed out, we paused the independent sector. That would allow those people to be treated again, so that would help. And secondly, on the 10 million, that absolutely would help in terms of the general trust pressures that are out there and minimising the impacts of the proposals that they've got in play and investing in domiciliary care. So absolutely would all help within that context.
So, thanks for that. So therefore, September 2014, you're saying 73,000 plus on 9 weeks for outpatients. How will that money affect that, or will it? And also then your inpatients sitting at 20,000 on 13 weeks. I'm thinking of the targets 9, 9, 13. I'm thinking of the 9 weeks. So you have 73,000 over target over the notional 9 weeks.
And the bid would allow us to treat 4,700 new outpatients coming off that 73,000.
Right.
And then on inpatients and day cases, it's 4,900 would come off on those, and another 7,500 off on diagnostics.
Okay. So then the magic question is to get that back down to where it should be, the 73,000, down to where the 9 weeks are notionally. What sort of money are you talking about? And also, when you're thinking about that, your impatience.
Certainly would need to work out in terms of what the 73,000 would require in terms of funding. What we had to bear in mind is what we can spend between January and the end of March, and hence why the
Thinking of next year,
the £13 million bid. So there are pressures in elective care next year, and we'll be coming back to that in the context of the 15-16 budget. Blatantly, there will be still a considerable number of those people who won't be able to be treated, even if we did get that funding. And that's simply a reflection of what is able to be spent between, in February and March. Yeah.
Yeah. Okay. Not a very pretty picture. Okay. Thank you.
Okay, thank you. Just a comment in relation to the bid for the 10 million on the frontline pressures. One of the issues coming out of our work around scrutiny of the budget going forward was there was a lack of definition around what frontline services are. So that's quite vague. How will it be spent? How will it be allocated?
I think that when we had the discussion about this before, it was in the context of the draft budget for 2015-16, and where the executive had said that there would be monies available for frontline health and social care services. And I think, if I recall the discussion, it was also then about what about other frontline services such as the fire service. And the discussion at that point was about this was the way that the executive draft budget paper had been agreed, and that only the health and social care elements of frontline had been effectively viewed as being funded. For this one, we're talking about trusts frontline pressures, so you are talking about monies going in to assist in patient and client care through the trust system. So it's not this money, if we got it, would only go into trusts, would not go into any other body, and would be assigned or allocated to services affecting patients and clients, and hence why the things that are listed within the actual bid.
Well, I mean, first of all, I would take issue because the Permanent Secretary told us in an evidence session that they didn't have a definition of frontline services when the direct question was asked. And in fact, it's an issue that we've highlighted in our response to the budget. So, I mean, he was very clear that he didn't have a definition.
There's no definition of what the executive meant by frontline health and social care pressures, which is what the wording within the draft paper says. What we're saying on this is that frontline pressures are within the trust, so it's absolutely viewed as being within the trusts, and it's for treatment of patients and clients.
I can accept that this part is within the trust, but I do maintain that it was very, very clear that it was in relation to the definition of frontline services when the direct question was asked, and indeed we have taken a recommendation forward in our response on that.
Okay.
In terms of just generally, Julie, the other issue that was raised for us in going forward was the over-reliance, if you like, on monitoring rounds. Can I take it, from today's evidence and going forward that it has been accepted that there's been an over-reliance, and that in going forward in terms of 15-16 there is a commitment that the department will live within its budget?
I think without getting into the 15-16 substantive debate, you'll be aware that we or propose that we could achieve a break-even position in 15-16 based on the draft budget allocations, however, with two very strong caveats. That we would still need to achieve significant savings in order to do that, and that there would be no monies available for service developments as we look ahead, which would be a matter of significant concern. Now, as we discussed, I think before, around 15-16, we then need to understand, well, what happens to that. We're obviously going into further conversations with DFP, final budget, and working through. But the aim, absolutely, as Permanent Secretary advised, is to identify a balanced plan going into the 15-16, and we need to identify a source of money for service developments. and that source doesn't exist at this stage. So we need to look at identifying that balanced plan, and we're committed to try and do so. But it's significantly challenging looking forward into 15-16. But I suspect you don't want to reopen that whole debate again.
Okay. No, well, thank you for that. And I suppose just, I mean, in conclusion, I think that the issue around the breakdown of the cost of the independent sector versus in-house is one that we want to have more detail on. In terms of that calculation, and I think also the breakdown of how the 10 million in terms of frontline pressures will be allocated or distributed would be useful as well. Okay, so thank you all for your time today. Thank you. Okay, members, moving on to item 13, which is matters arising. There's one item under matters arising in the meetings folder, 3 items in your tabled folder, and 1 item on members' tables. So on page, just drawing your attention to a number of them, page 307 is correspondence from the Minister providing a response to the recommendations contained in our review of supported living for older people in the context of transforming your care. The response isn't very clear in terms of which recommendations the Department have accepted and which it has not, and there's certainly a lack of information on timescales. There's reference in the response to the DSD review of supporting people and to a project the Department of Health intends to undertake under Delivering Social Change. The review of supported living is due to be completed by March 2015. So I'm seeking agreement, members, that if members are in agreement, to arrange an oral evidence session with officials in April for an update on the outcome of the review and progress on the Delivering Social Change project.
Just Paul and I are in the DSD committee. We've had a briefing on that budget, and it seems that the supported living is going to the end. Possibly some reduction, but not. I think there's a commitment that it is an essential part of the DSD commitment. So that's going to be okay. Okay, members in agreement then that we progress as suggested on terms of the oral evidence session in April. Okay. Page 9 of the tabled folder is a response from the Minister to the committee's request for further information on the programme for Government Commitment 80, which we had some discussion recently on, which is by 2014-15 to have transferred 83 million from hospital-based services to community primary-based services. The Department again is planning to shift left 2.53 million in 14-15 and 0.93 million in 15-16. Again, members, this definitely seems at odds with what we were told at last week's PFG briefing, when officials again were adamant that the target was on track for the 83 million, and indeed it was ranked as green or amber. It would suggest to me that that's not anywhere near the 83 million shift, and therefore it's certainly not on track or not on target. The item on the members' tables is a response from the Minister regarding a briefing on the PPRS and Cancer Drugs Fund. The Minister has now apologised for the late response. He has advised that the evaluation of the individual funding request policy will be completed by the end of the year, and it is of the view that it would be preferable for the findings to be considered and a decision made on the way forward before the committee is briefed. Officials will be available to brief the committee from mid-January 2015, informing members that a briefing on the issue will be factored into the committee's forward work programme. Okay, members content? Item 14 is correspondence. There's 11 items of correspondence and 5 items in the tabled papers. Again, in the interest of time, I'm just going to draw attention to several of them. Page 318 is correspondence from the Minister providing a report on the responses to the consultation on the policy for the NI Firefighters Pension Scheme. 2 organisations have responded to the consultation, the Fire Brigades Union and the NI Fire and Rescue Service, informing members that draft regulations will be referred to the committee for scrutiny in January. The timescales for implementing the regulations will be tight, given that there will be significant financial implications if deadlines are not met. So at this stage,
I'm asking, do members require any further information on the issue from the department? Are they happy with the scrutiny process taking place? Are members comfortable with that? Okay, thank you. Page 346 is correspondence from the Chartered Society of Physiotherapy advising that the project board for physiotherapy self-referral has been stood down. Strange decision, to say the least, given the fact that this pilot has been advocated as a key component, if you like, in terms of even shift left and taking pressure off GPs and our A&Es. Seeking agreement to write to the department for clarification on the rationale for this decision.
Yeah, Chair, I mean, that is very disappointing because we were almost promised by some of the senior officials that this would come into being, and we were delighted that that was, coming to be, and to be told now that is
Important word is
disgraceful, I would say.
Thank you, and we will certainly raise that with the department, seek that clarification. I agree. Page 349 is an invite from the Northern Ireland Social Care Council to visit its premises. I'm seeking agreement members to write back to the organisation and advise that we will consider this invitation further in January when we are meeting to agree our forward work programme. Members comfortable in agreement with that? 352 is correspondence from the Senior Manager of the Institute for the Disabled regarding the impending closure of Stewart Memorial House in Bangor. Seeking agreement to respond, advising that the committee has consistently taken a position of not becoming involved in individual issues and suggest that they contact the constituency MLAs for support on this.
Agreed.
Okay, page 28 of your tabled folder is correspondence from Suicide Down to Zero, requesting to brief the committee on its work. Seeking agreement for the group to be invited to the next committee stakeholder event.
Agreed.
Seeking agreement to note the remaining correspondence unless members have any comments they wish to make. Item 15 is any other business.
Chair, could we...
Hold on, sorry, somebody had indicated before you.
Sorry.
Paula.
Thank you, Chair. As you're aware, you attended our last sexual health all-party group, and it was discussed at the possibility of the Health Committee doing a visit to the Gum Clinic in the Royal. I don't think there's ever been a visit by the Health Committee at any stage up to them. They do some vital work up there under immense pressure, and I think they're one of the Cinderella parts of the health service that we really do not hear from very often, and yet they're working under extreme pressure. So I would just ask if we could get that put down somewhere for the future. I'm not saying we have to do it next week or next month, but in the future, I think it would be a worthwhile visit. It would be worthwhile for them as well to know that we're actually interested in what they're doing and understand the pressures that they're under as well.
Happy to do that, and I think we could factor that into our forward work programme. We're meeting to discuss that, I think, on the 14th of January, so we can confirm it then. Pam was just in front of you, and then yourself, Kieran.
Thank you. Thank you, Chair. On Monday, I'm sure you're all aware that Una Hutton was buried, and I was able to attend the service there in Polglass, and I have to say it was amazing to see such a huge turnout, but I would have expected that. But more than that, it was amazing to see the huge turnout of Teal, and I think that was the absolute evidence that Una was extremely successful in her short, very intense campaign that she had to raise the issue of ovarian cancer, and the work that we all know she did, and that came from PHA. And I think it would be fitting if this committee would agree to send either a sympathy card to your husband Felix or a letter to express this committee's sympathy on a huge loss, which is Una Crudden. She was, well, we all know, I think we all met her, very touched by her and by her amazing strength and her selflessness and the time that she gave, the last years of her life that she gave over to this campaign for others, and I think that should be recognised by this committee.
Absolutely, I couldn't agree more, and I think that there's no doubt that the role that she played brought that awareness We might have wanted more, but certainly put it very clearly on the agenda, and I think it would be right and proper that we would send our thoughts to the family.
Yeah. Yeah. Well, just to, I mean, I called up at the funeral home on Friday because I heard it in the news on the wireless, and it just strikes you it can't be right, But we knew that it was coming, and she was a fantastic lady, in the work that she's done. And you're right, Pam, that we should acknowledge that to the family, and certainly, it was sad to see, but there we go. So I fully support it.
Yes, I'd like to concur with the comments. I think all our lives were enriched by knowing her. She was so determined, and as Pam said, she devoted the last months of her life, and she knew it was too late for her, but her role was to save others, and I think she was such an inspirational lady, and I think we should be remiss of us not to acknowledge that, and she will be a big loss.
Absolutely. Okay, members, thank you for that. Kieran, you had another.
Yeah, but Chair, I don't know if anybody's seen the programme last night, television, about the abuse in a home. It wasn't in this jurisdiction, it was a few miles across the border, and I would very much worry that something similar. You think it can't happen, but it happened. Did anybody see it?
I didn't.
No, it was a program. It was a home. I mean, I'm talking from experience because I have a daughter and she's in the home at this moment in time. And if I thought that she was having to endure anything like what happened, it was horrendous. People, that defenceless people, the abuse. And all I'm saying is that if it can happen a few miles across the border, it could very well happen in our areas. And is there any way that we could maybe draw attention to, the authorities to ensure that it's not happening anywhere in our areas?
Well, I mean, you're right, and I think that the figures of abuse amongst older people, and we had the evidence session recently from the Commissioner, have trebled, and even the issues around the lack of definition of what abuse is. So, I mean, what I'd suggest, there is an adult safeguarding policy being drafted, which is to explore the issue of the need for actual legislation. I think we could seek an update as to that safeguarding policy, how proactive it's going to be, and will it start to address issues around the protection of older people. And I think also as well the protection of staff in some of these situations.
This wasn't necessarily older people, it was people with learning disabilities that just do not know, and it was shocking. I couldn't watch it all, to tell you the truth. It was so bad.
Oh, just as an interesting statistic out a couple of years ago, about 4% of the elderly population in residential here, 23% of the calls to the Elder Abuse Helpline came from residentials, so it's disproportionate. Now, obviously that's not an attack on residentials because the vast majority of them are excellent. As Kieran says, there are cases in residentials because people are now a commodity. It's a business, and I think we shouldn't get away from that fact. And a lot of there's profit to be made, and that's why there's so many. If you go back in our constituency 20 years ago, there's probably about 15 or 16 statutory residentials. Now there's 2, but 1 in I think. So it's huge difference, and I think it's something best. Or QAA, if they're not doing their job, that's what they're there for. They're there to do inspections, and maybe that's something like that.
Yeah.
What I was going to suggest, Kieran, I mean, and you're right to raise it, is that we could look at generally, I mean, there's a role for RQIA and all of this as well, but that certainly this as an issue, if it is an issue of concern for this committee, that on the 14th of January that we reflect on it in terms of our role in terms of a forward work programme. So happy to do that.
Okay, thank you.
Okay, members, the next committee meeting is on the 14th of January 2015. We'll do an informal strategic planning meeting, first of all from 1 o'clock to 2 o'clock. And can I just take the opportunity to wish you all a very happy and peaceful Christmas?
Same to you,
Chair. Thank you.
Got us out early, anyway.
It's your Christmas present.
That was great.